Disorders of white cells, leukocytosis, neutrophils or polymorphonuclear neutrophils, 50 to 70%. This is by far the commonest cause of leukocytosis. Increased means more than 7,500 per cmm. This is called neutrophilia. Physiological from severe exercise, stress, last months of pregnancy, and newborn. Pathological due to bacterial infection, non-infective tissue damage, myocardial infarction, pulmonary infarction, pancreatitis, burn, metabolic disorder, DKA, uremia, acute gout, myeloproliferative disorders, drugs, steroids, adrenaline, and digitalis. Decreased means less than 2,000 per cmm. Neutropenia or granulocytopenia or agranulocytosis. Mild decrease is referred to as neutropenia, and the severe decrease is called agranulocytosis. Due to infection, viral, typhoid, brucella, immunological, SLE, and Felty syndrome, iatrogenic, cytotoxic agents, phenocyanidins, NSAIDs, antithyroid drugs, aplastic anemia, megaloblastic anemia, hypersplenism, benign familial neutropenia, feature of rare families associated with mild neutropenia but no propensity to infection. Basophils, 0 to 1% function, they combine with IgE, causing release of histamine and other contents involved in acute hypersensitivity, increased more than 100 per cmm basophilia from myxedema, mastocytosis, Hodgkin disease, myeloproliferative disorders, CML, polycythemia vera, decreased basophilopenia, pregnancy, acute rheumatic fever, steroid therapy, cytotoxicosis, and stress. Eosinophils, 1 to 5% increased more than 400 per cmm eosinophilia due to allergy, bronchial asthma, eczema, Addison disease, ankylostoma, ascaris, filaria, parasitic infections, vasculitis, Churg-Strauss syndrome, polyarthritis nodosa, neoplastic eosinophilic leukemia, Hodgkin disease, hypereosinophilic syndrome, decreased less than 50 per cmm, eosinopenia, steroids, Cushing syndrome, acute stressful conditions, lymphocytes, 20 to 45% increased more than 4,000 per cmm, lymphocytosis, lymphatic leukemia, lymphoma, especially lymphocytic lymphoma, lymphocytosis is normal in infancy, bacterial infection, TB, brucella typhoid, viral infections, measles, smallpox, influenza, hepatitis, infectious mononucleosis, decreased less than 1,500 per cmm, lymphocytopenia, normal in 22% of the population from stress, steroids, SLE, some viral infections such as HIV, and suppression of bone marrow after chemotherapy. Then we have atypical lymphocytosis from leukemia lymphoma, viral hepatitis, infectious mononucleosis, cytomegalovirus, and toxoplasmosis. Monocytes, 3 to 7%, originating in the bone marrow, then circulating in the blood to the tissue converted to macrophages. Increased more than 800 per cmm, monocytosis, infection, TB, subacute bacterial endocarditis, brucellosis, typhoid, infectious mononucleosis, malaria, leukemia, Hodgkin, inflammatory bowel diseases, ulcerative colitis. Decreased less than 200 per cmm, monocytopenia, steroids, interferons, SLE, lymphocytic leukemia, aplastic anemia. Hypereosinophilic syndrome, myeloproliferative disorder characterized by 3 features: persistent eosinophilia, 1,500 or more per cmm for at least 6 months. No identifiable etiology for this eosinophilia is present. Patients must have signs and symptoms of organ involvement such as skin rash, thromboembolic diseases, neuropathy, splenomegaly, and cardiomyopathy. It's a diagnosis of exclusion. If left untreated, then it's fatal. In the heart, there are 2 forms of hypereosinophilic syndrome: endomyocardial fibrosis and Loeffler's endocarditis. Treatment: steroids and hydroxyurea, monoclonal antibody, mepolizumab, surgery, splenectomy, and valve replacement. Leukemia definition: malignant proliferation of immature WBCs primarily in the bone marrow, and then they circulate peripheral blood and infiltrate other tissues. Classification of leukemia: acute, chronic, acute lymphoblastic leukemia, acute myeloblastic leukemia, AML, ANLL, chronic leukemia, chronic myeloid leukemia, and chronic lymphocytic leukemia. Etiology unknown, but genetic and environmental factors may play a role. Genetic factor: incidence of leukemia increased in identical twins. High incidence is in certain chromosomal disorders such as Down syndrome, Klinefelter syndrome. presence of chromosomal abnormalities in certain types of leukemia, Philadelphia chromosome in CML, environmental, radiation, increased incidence in survivors of Hiroshima and Nagasaki and in patients treated with ionizing radiation, chemical and drugs, benzene, chlorambucil, viruses. Leukemias are associated with human T-cell lymphotropic virus, HTLV1, which is found particularly in Japan and the Caribbean. Pre-existing hematological disorders, myelodysplastic syndrome, acute leukemia, malignant proliferation of immature WBCs or blast cells. Classification: acute lymphoblastic leukemia, common in children, 80% of the acute leukemias in childhood, peak incidence between 3 and 7 years. Acute myeloblastic leukemia, common in adults. Clinical picture: we have bone marrow failure and organ infiltration. Bone marrow failure, blast cells proliferate in uncontrolled manner, replacing the normal bone marrow elements. RBCs, severe progressive anemia, platelets, purpura, menorrhagia, epistaxis, bleeding gums, rectal and retina. Platelets, YBCs, fever, recurrent infections, common pathogens, gram-negative bacteria, E. coli, Pseudomonas, gram-positive cocci, Staph aureus, fungi, Candida, Aspergillus, viruses, herpes simplex. Common sites for infection: mouth, throat, skin, lungs, anorectal region, urinary tract. Deaths within few hours may occur if treatment with appropriate antibiotics is delayed. Organ infiltration: bone marrow infiltration, bone pain, tender sternum, generalized lymphadenopathy, especially in ALL, cervical, mediastinal, porta hepatis, lymph node, hepatosplenomegaly, other organs affection, infiltration, infection, infarction due to leukostasis, occlusion of the microcirculation leading to ischemia and hemorrhage. Kidney, acute renal failure, especially during treatment, or pyelonephritis. Skin, pruritus, nodules, chloromas, soft tissue masses, which may occur in AML. CVS, cardiomyopathy. CNS, paraplegia, meningitis, increased intracranial tension. Lung, hemoptysis, infections. Gum hypertrophy, testicular infiltration, venous priapism. Investigations: CBC, YBCs usually increased up to 100,000 per cmm, but YBCs may be low. RBCs decreased, normocytic normochromic anemia, platelets decreased, blast cells they are present and increased, lymphoblasts or myeloblasts. Cytochemical stains, immunological markers, and cytogenic analysis are necessary to differentiate between AML and ALL. Subleukemic leukemia, subnormal YBCs with presence of blasts. Aleukemic leukemia, no blast cells. Bone marrow examination: more than 20% of the blasts are required to make diagnosis of acute leukemia. Others: uric acid, LDH are elevated. Serum electrolytes may be affected due to diarrhea, vomiting, or chemotherapy. CT brain, CSF examination, renal function test. How to differentiate between ALL and AML. Morphology: myeloblasts look similar to lymphoblasts. Presence of air roads in the cytoplasm of blasts are diagnostic of AML. Cytochemical stains: Sudan black stain is positive in AML, negative in ALL. Enzymes: increased deaminase in ALL. Muramidase enzyme is present in AML. Immunological markers. French, American, British FAB classification of AML. Morphological background: M0, 1, 2, 3, 4, 5, 6, 7. And we have FAB classification for ALL, L1, 2, 3. L1, cells, small, homogeneous, child variant. L2, large, heterogeneous, adult variant. 3, large, Burkitt-like cells, aggressive type associated with Burkitt's lymphoma. This is the classification for ALL. Classification for AML or AML: M0, undifferentiated leukemia. M1, myeloblastic leukemia without maturation. M2, myeloblastic leukemia with maturation. M3, promyelocytic leukemia associated with DIC. M4, myelomonocytic leukemia. M5, monocytic leukemia. M6, erythroleukemia, red blood cell precursors and myeloid blasts. And finally, M7, megakaryoblast leukemia, extremely variable morphology and very bad prognosis. Differential diagnosis: causes of fever with sore throat, rheumatic fever, infectious mononucleosis, bone marrow failure, aplastic anemia, and causes of lymphadenopathy. Treatment: general supportive treatment, RBCs and platelet transfusion will continue through treatment. Antibiotics for infection, allopurinol to prevent hyperuricemia. Chemotherapy, Acute lymphoblastic leukemia, we have 4 steps. Induction of remission, CNS prophylaxis, consolidation, and maintenance. Induction of remission, VAP, vincristine, adriamycin, prednisolone. Aim to achieve complete remission, no evidence of leukemia in the blood, normal blood count, and less than 5% blasts in the bone marrow. Vincristine is given 1.8 mg per meter square per week, IV for 4 weeks. Adriamycin 40 mg per meter square per week, IV for 4 weeks. Prednisolone 40 mg per meter square per day, orally, for about 4 weeks. Poor prognosis, age less than 2, more than 10 years, WBCs more than 50,000, CNS manifestations, platelets less than 25,000, FAB classification L3, which was large Burkitt-like cells. CNS prophylaxis, cranial irradiation, intrathecal methotrexate. Consolidation therapy given after complete remission achieved to reduce risk of relapse consists of either the same drugs, those used in induction of therapy, or other cytotoxic. Maintenance for about 2 to 3 years, mercaptopurine daily, methotrexate weekly, and prednisolone monthly. Acute myeloblastic leukemia, induction of remission, cytosine arabinoid, 100 mg per meter square per day for about 1 week, adriamycin, 45 mg per meter square IV for 3 days, CNS prophylaxis, not used in treatment for adult AML, consolidation consisting of same drugs or other cytotoxics, maintenance therapy. In treatment of AML, there is controversy over the use of maintenance therapy, not thought to be of any benefit in most patients. Bone marrow transplantation is the treatment of choice. In general, response to treatment and prognosis are better in patients with ALL than patients with those AML. Prognosis: without treatment, acute leukemia is fatal within few months. Cure rate with chemotherapy for AML 30%, over 60 do worse, and ALL children 90%, adults 60%. Causes of death: recurrent infections, multiple organ failure, cerebral or internal hemorrhage. Then we have chronic myeloid leukemia. Chronic myeloid leukemia, myeloproliferative disorder characterized by overproduction of myeloid cells. Clinical picture: CML, more common in middle age and old age males. 30% asymptomatic at diagnosis, present after routine CBC, fatigue, and weight loss. Organ infiltration, the same as acute leukemia, but it begins with splenomegaly, huge spleen, dragging pain in the left hypochondrium, stitching pain due to splenic infarction. The spleen is hugely enlarged and maybe with multiple notches and splenic rub. Generalized lymphadenopathy, cervical, mediastinal, portahepatis may occur. Bone marrow infiltration, tender sternum, bone pain. Other organs affection, rare in CML, infection, infiltration, infarction due to leukocytosis, occlusion of the microcirculation leading to ischemia and hemorrhage. Skin, pruritus, nodules, cardiomyopathy, paraplegia, meningitis, increased intracranial tension, hemoptysis infection, gum hypertrophy, testicular infiltration, and penis priapism. Acute renal failure, especially during treatment, and pyelonephritis. Bone marrow failure, anemia, purpura, fever, recurrent infections, menorrhagia, epistaxis, bleeding gums, rectal, and retina. Blastic crisis, patients may develop transformation into acute myeloblastic leukemia. Then we have investigations. CBC, WBCs, the total WBCs count increased more than 100,000 per cmm, mainly in the form of myelocytes and promyelocytes. Myeloblasts is usually less than 5%. Marked myeloblasts occur in blastic crisis. RBCs decreased, but not as those in acute leukemia. Platelets, initial rise, then it drops with progression of disease. Bone marrow examination, hypercellular, full of myelocytes with few myeloblasts. Increased myeloblasts occur in blastic crisis. Philadelphia chromosome, its translocation between chromosome 9 and 22 appears in all bone marrow derived cells except T cells, positive in most cases, more than 90%. Philadelphia positive patients have better prognosis than Philadelphia negative patients. Others, elevated uric acid and LDH. Leukocyte alkaline phosphatase is decreased. differential diagnosis for huge splenomegaly, bilharzisis, malaria, chronic myeloid leukemia, hairy cell leukemia, thalassemia, polycythemia, myelofibrosis, and myelosclerosis. Leukemoid reaction, marked leukocytosis, 50,000 per cmm due to aggressive response of the bone marrow. Causes, severe hemolysis, paramalignant syndrome, infection, severe or chronic STB, may be distinguished from chronic myeloid leukemia by measurement of the leukocytes alkaline phosphatase, elevated or normal in leukemoid reaction, but it's depressed in CML. Treatment, general supportive treatment, same as acute leukemia, RBCs and platelet transfusion, antibiotics for infection, allopurinol to prevent hyperuricemia, with leukophoresis for leukostasis. Chemotherapy, busulfan or myliran, 4 to 8 mg per day orally. The dose is reduced with reduction of the total leukocytic count. Side effects, aplastic anemia, vomiting, diarrhea, and gonadal atrophy. Hydroxyurea, 1 to 6 gram per day orally. The dose is reduced with reduction of total leukocytic count. Side effects, rash, mouth ulcers, and diarrhea. Radiotherapy, irradiation of spleen in cases of huge spleen. Bone marrow transplant, option of choice in young and fit patients. Treatment of plastic crisis similar to AML. Other drugs recently used in CML, interferon 3 million units subcutaneously 3 times per week, and imatinib, tyrosine kinase inhibitor, dose 400 mg per day orally. Then we have chronic lymphocytic leukemia. Malignant proliferation of small lymphocytes, almost always 99% B lymphocytes. Commonest leukemia in adults, 25 to 30% of all leukemias. Clinical picture. CLL is a disease of older patients more than 50 years, 2 to 1 males to females ratio, asymptomatic. Lymphocytosis on routine CBC, lymphadenopathy, painless and usually symmetrical, splenomegaly, hepatomegaly in 50% of the cases, bone marrow failure due to infiltration, anemia, thrombocytopenia, and bleeding tendency, recurrent infection due to acquired hypogammaglobulinemia, especially herpes zoster, patients with advanced disease, weight loss, night sweats, and malaise. Staging of CLL, Ray modified staging, 0, 1, 2, 3, 4, 0, lymphocytosis only, 1, plus lymphadenopathy, 2, organomegaly, 3, anemia, 4, thrombocytopenia. We have lymphocytosis in all cases, so only lymphadenopathy, organomegaly, anemia, thrombocytopenia. And I'm sorry to do the Manal Wadia style. Investigations, CBC, WBCs. The hallmark of CLL is isolated lymphocytosis. White blood cell count elevated and may be markedly elevated up to million per cmm. Usually 80% of the circulating cells are lymphocytes. Lymphocytes appear small and mature. RBCs and platelet count, usually normal at presentation. Autoimmune hemolysis or autoimmune thrombocytopenia may occur late in the disease. Bone marrow examination, more than 30% lymphocytes. Lymph node biopsy, rarely required. Appearances of lymphocytic lymphoma. Treatment, many patients with CLL require no treatment, living at peace with their lymphocytosis to die of unrelated complaint. Supportive treatment as usual, such as CML. Specific treatment, chemotherapy, chlorambucil or leukeran, 6 to 10 mg per day orally. Radiotherapy, irradiation of lymph node and spleen. Splenectomy for massive splenomegaly or hypersplenism. Hairy cell leukemia, rare B-cell lymphoproliferative disorder associated with splenomegaly, pancytopenia, and typical hairy cells in blood and bone marrow. Mostly in middle-aged males with male to female ratio 5 to 1. Treatment, splenectomy in severe cases, supportive treatment as usual, and cladribine 2-chlorodeoxyadenosine CDA infusion of 0.1 mg per kilo per day for 7 days. Lymphoma. They are divided into Hodgkin and non-Hodgkin lymphoma based on histological presence of Reed-Sternberg cells. Hodgkin lymphoma, malignant lymphoma characterized by Reed-Sternberg cells. Incidence, age, one major peak in the 20s and second over 50 years. Bimodal age incidence, sex higher in males. Risk factor, Epstein-Barr virus increases the risk of Hodgkin lymphoma in individuals with history of infectious mononucleosis. Positive family history. Clinical picture, lymph node enlargement, painless, non-tender, discrete, rubbery, lymphadenopathy. Frequently cervical 60 to 80%, axillary in 20%, and inguinal in 5%. Mediastinal lymphadenopathy may produce local symptoms, bronchial or superior vena cava compression, or direct extension to pleura, pleural effusion in 20%, hepatosplenomegaly, papillosplenomegaly in 10%, and hepatomegaly in 5%, bone marrow involvement, rare, 1 to 4%, anemia, bleeding tendency. Then we have systemic symptoms, 30%, fever, Pilbstein fever, intermittent fever, weight loss, night sweats, generalized pruritus, alcohol-induced lymph node pain. Clinical stages of Hodgkin lymphoma, stage 1, 2, 3, 4. 1. Involvement of single lymph node region. 2. Two or more lymph node regions on the same side of the diaphragm. 3. Involvement of lymph node regions on both sides of the diaphragm, plus or minus involvement of the spleen. 4. Involvement of one or more extranodal sites, bone marrow or liver. And each stage is furtherly subdivided into A and B. A. Absence of systemic symptoms. B. Presence of systemic symptoms such as fever, night sweats, and weight loss. Investigations. Lymph node biopsy. The most important diagnostic test, presence of Reed-Sternberg cells surrounded by inflammatory cells. Hodgkin's disease is histopathologically divided into 4 subtypes: lymphocyte predominance, best prognosis; lymphocyte depletion, worst prognosis; nodular sclerosis, most common in adults; mixed cellularity, most common in children. Biopsy of other sites may be necessary, liver or bone marrow. Radiological, chest x-ray, CT chest, abdomen, pelvis, isotope, bone scan, MRI may be necessary. Hematological and biochemical findings, CBC may be normal. Lymphopenia, neutrophilia, eosinophilia, thrombocytosis may be present, and there may be normocytic normochromic anemia. ESR, LDH, and calcium are elevated. Liver function tests, elevated transaminases may indicate liver involvement. Treatment, symptomatic treatment, blood transfusion, antibiotics. Specific treatment, radiotherapy for early stages 1 and 2A, chemotherapy for later stages, combination chemotherapy protocols with or without radiotherapy, ABVD, MOPP, COPP. ABVD, adriamycin, bleomycin, vincristine, and dacarbazine. MOPP, mustin, oncovine or vincristine, procarbazine, and prednisolone. COPP, cyclophosphamide, oncovine or oncovine, I'm not sure, procarbazine, and prednisolone. ABVD has much lower risk of infertility than MOPP regimens and not associated with increased risk of leukemia. Surgery indicated in pressure manifestations or gastric lymphoma. Non-Hodgkin lymphoma includes all lymphomas without Reed-Sternberg cells. Incidence old age from 65 to 70 years. Higher incidence in males. Risk factors: infection, Epstein-Barr virus, Burkitt lymphoma, Helicobacter pylori, gastric malt lymphoma MALT, immunodeficiency, immunosuppressive drugs, transplantation, HIV, connective tissue disorders, Sjogren syndrome, chromosomal translocation between long arms of chromosome 8 and 14. Clinical picture as Hodgkin disease. The disease is more aggressive than the Hodgkin. Hard lymphadenopathy. Involved lymph nodes may be present also in the retroperitoneum, mesentery, and pelvis. Abdominal pain, abdominal mass in Burkitt lymphoma, usually disseminated at the time of diagnosis. So if we're going to compare between Hodgkin's lymphoma and non-Hodgkin's lymphoma, age, young in Hodgkin, site, unicentric, skin overlying is normal, rubbery consistency, mobile, and good prognosis. Non-Hodgkin lymphoma, old, multicentric, red, hot, dilated veins in the skin overlying, hard in consistency, amalgamated or confluent, not mobile, bad prognosis. Classification of the non-Hodgkin lymphoma: indolent lymphoma, low grade, aggressive, intermediate, and very aggressive, high grade. Indolent, such as follicular lymphoma, grade 1 and 2, 20%, MALT, multiple lymphoma, small lymphocytic lymphoma. Aggressive lymphomas, such as follicular lymphoma, grade 3, mature T-cell lymphoma, mantle cell lymphoma, diffuse large B-cell lymphoma, 30%, very aggressive or high grade, Burkitt lymphoma, 2%, precursor T lymphoblastic lymphoma. Burkitt lymphoma, male to female ratio 2 to 1, presents with bulky central nodal disease, plus or minus extranodal involvement, typically in the abdomen, bone marrow, and or CNS involvement. Investigations such as Hodgkin lymphoma but no Reed-Sternberg cells. Treatment: low-grade non-Hodgkin lymphoma. If asymptomatic and low-grade, no treatment is needed. Radiotherapy to involved nodal regions. Single-agent chemotherapy, chlorambucil. Intermediate and high-grade, combination chemotherapy, COPP, cyclophosphamide, oncovine, procarbazine, and prednisolone. Lymphoblastic non-Hodgkin lymphoma, treated as acute lymphoblastic leukemia. And then we have causes of generalized lymphadenopathy: infection, viral, infectious mononucleosis, hepatitis, bacterial, TB, brucellosis, protozoa, toxoplasmosis, fungal, histoplasmosis, tumors, Hodgkin and non-Hodgkin lymphoma, leukemia, ALL, AML, CLL, CML, metastasis, immunological, SLE, Sjogren syndrome, others, amyloidosis, sarcoidosis, hyperthyroidism, and drugs such as phenytoin. And if we're gonna compare and differentiate between each one of them, sarcoidosis, suggested by dry cough, breathlessness, malaise, fatigue, weight loss, enlarged lacrimal glands, and erythema nodosum, confirmed by chest X-ray, bilateral lymphadenopathy, and tissue biopsy showing non-caseating granuloma. Acute lymphoblastic leukemia, suggested by anemia, bleeding, tender sternum, hepatosplenomegaly, the same as acute myeloid leukemia, confirmed by increased WBCs, blood stills in blood and bone marrow, and the same goes for acute myeloid leukemia. Drug effect, suggested by drug history such as phenytoin, confirmed by improvement when the drug is withdrawn. Chronic lymphocytic leukemia, suggested by anorexia, weight loss, enlarged rubbery non-tender lymph nodes, hepatosplenomegaly, bleeding, anemia, confirmed by marked lymphocytosis and bone marrow infiltration, while chronic myeloid leukemia, suggested by splenomegaly, variable hepatomegaly, bleeding, anemia, confirmed by presence of Philadelphia chromosome and elevated YBCs more than 100,000 per cmm. Hodgkin and non-Hodgkin lymphoma, confirmed by presence or absence of Reed-Sternberg cells and suggested by anemia, splenomegaly, lymph node enlargement, whether multiple or single. Infectious mononucleosis, glandular fever due to Epstein-Barr virus, suggested by very severe throat pain, enlarged tonsils covered by creamy membrane, petechial and palate, profound malaise, generalized lymphadenopathy, splenomegaly, confirmed by Pol Banel test, positive, and viral titers. And this concludes our part for today and the whole hematology.